Welcome to E360 TV, the live streaming and on-demand destination for influential voices and enlightened audiences. We offer trending, grassroots, and purpose-driven content across a diverse range of interests. E360 TV is more than just watching programs. We offer the ability to interact with live shows connecting audiences to real, authentic influencers and storytellers while streaming to millions of devices. Real experiences. Raw conversation. One destination for it all. E360 TV.
You all are looking awfully good to me today. I don't know what's in the air or what's in the water, but I like it. Good morning and welcome to today's installment of Bathrobe Moments. And I'm your host, Lauren Michaels Harris. We are on our second show from the new studios down here, now known as, are you ready? Imagine Studios. Now imagine that. That's right. I tell you guys all the time, I don't think I'd rather be anywhere else in the world, except maybe Fiji, than right here with you all. Absolutely the truth. That's the bell of purpose I keep hitting. You hear it in the background. Why is that there? Not just some simple little gimmick or show prop or anything like that. The bell of truth, the bell of purpose, if you will, is a reminder to sit in, lean in, tune in. When you hear that bell ring, just like the bell has a ring to it, so does the truth. I know we're busy nowadays with this new everything, and we do tons of things all at the same time, multitasking to the nth degree. But when you hear the bell ring, it means back that car up, back that thing up. I got something I'm sure you're going to want to take with you. Can I get an amen? Okay, so here we are. Welcome to the third day of November. We're almost there. It's Thanksgiving month, y'all. I was in the grocery store yesterday, and they had all those turkeys. I wait till they go on sale for 99 cents a pound. I don't know about you, but I do. And so all the stuff out, all the fixings are in the middle of the rows and stuff like that. So what are your plans? A lot of people telling me that a lot of families are opting to have a vaccinated holiday in one location, a non-vaxxed holiday at another location, and never shall the two meet. So I don't know. I'll tell you, my husband and I, Brian, we're keeping it. We usually host Thanksgiving, but we're not this year. We're keeping it home, just us and the two kitties. That's what we're doing. I don't know. It's just too much. All this stuff going on. I don't know. You guys have that in your families and friends where I don't want to be around anybody that's not vaxxed or whatever. I don't know. It's a respect issue. It is a choice, and a choice for your own body is something that you alone should be able to make, right? And that kind of ties into what we're going to talk about here today. What choices we make. I'm 59 years old, headed really closely to that round. As soon as I round that corner of January, I'm going to be seeing the finish line of 60 right ahead, July 4th for me. And I know when I fell asleep, or woke up rather, they put me to sleep. When I woke up at 50 during the middle of my colonoscopy, I was telling actually Dr. B, who is here, Bucher, I was telling him this story. I woke up in the middle of my colonoscopy just for a second, but I saw inside my body. And what a wake-up call, literally, that was for me. I was like, wow, there's really a lot of shit going on in there, right? Oh, wait, that's a good butt doctor joke right there. I got some, too. Don't think I don't. Y'all know I do. Look, clearly I like to play. I just never grew up. Don't plan to either. So, we're going to talk about today HPV. Are you familiar with that? I just got the second part. I think there's three. The second part of that vaccination series 2 days ago. And I got my flu shot. So they did one over here, one over here. Yes, I did. Now, HPV, human papilloma virus, or is it papilloma? I don't know. Y'all know the rule. And I'll let him get away with it today, but don't play with me. No words over 6 syllables. Y'all know I got a public school education, and I'm just saying. So I don't know. We're going to find out. There is a difference, and there's a lot of great things about have you ever heard of anal dysplasia? Have you? Okay, well, we're going to learn a lot today, and we're going to learn it from Dr. Gary Bucher. He is the medical director and the founder of the Anal Dysplasia Clinic MidWest. Now, he has a medical practice which is dedicated to the anal health of men and women with HPV-related anal disease. Now, Dr. Bucher graduated from the University of Missouri, Kansas City School of Medicine back in 1989 when he was just a young buck. And he just holds all these different certifications and degrees. You know how they have them. And most of these words, let me see, which ones can I get away with? Okay, he's published and presented papers. I can read that. Here's something. The rates of anal cancer have been increasing in HIV-positive men and women, HIV-negative MSM, whatever that stands for, we're going to find out, transplant patients, and women with a history of cervical, vulvar, or vaginal high-grade dysplasia and cancer. So today, I want Dr. I would just say B because it's Bucher, but I made a joke with him when I first met him. I was like, if you put a T in there, you'd be Bucher. Now I say that in my mind all the time, and I don't want to mispronounce it. Dr. B, I love you. So listen, according to the University of Iowa Hospital and Clinics, they say that, what is anal dysplasia? Anal dysplasia, it is a precancerous condition in which lesions have formed in or near the anal canal. Now, anal dysplasia is not cancer, but anal dysplasia lesions can turn into cancerous tumors. So it's important to get screened. And I also found out, there is a difference. Some people confuse anal cancer with rectal cancer due to primarily the proximity. But these two diseases and the treatments of them are different. Colorectal cancer, for example, is primarily something with a whole bunch of syllables in it, and I can't say it starts with an A and it ends with an A. And anal cancer is usually something which is, what is that? Squamous cell? Oh, Lord. I knew not to try. I tried to sneak up on that word. Sound it out. Remember that? Didn't work. Anyway, good thing Dr. B is here because he's got all that great stuff for us. So we're going to, let's see. Oh, here, let's get this out of the way so he can just have the floor. I want to take you guys really quick. We're going to have about 2 minutes worth of video. So I'm going to show you the first thing because we want everybody to understand whether you have children, if you're a female, if you're straight, bi, gay, whatever, human. It's why it's called HP, human papilloma. Now, I don't think you need to take your pets to get screened, but that's about the only thing in your house with a heartbeat that doesn't need to be screened. Okay, am I clear? There we go. So, here we go. I want you to take a look at this, and then we'll get him in here, Dr. B. Let's see. Which one do we want? Okay, let's go to this one. So, this is from the CDC. Take a look.
Hi, Amy.
Hi, Jackie.
I have a medical question for you.
Okay.
So I just got back from getting Philip's HPV shot.
Oh, that's great.
But how do I know if it works? I mean, does it really prevent cancers?
Yes, HPV vaccine prevents infections that cause some cancers. Since the vaccine has been available, types of HPV that cause cancer have gone down significantly in young people in the U.S.
Oh, wow, that's pretty amazing.
I know, it really is.
Okay, great. Thank you.
Anytime.
Okay, so that was easy. So now I want to give you another peek into something that was on ABC. Then we're getting Dr. B in here. So get your questions. Don't be afraid to ask. If you don't want us to know who you are, go watch on any of my other 14 platforms. Get off the Bathrobe Moment, go to my website, or go to any of my other platforms that I go live on, and you can just be a Facebook user, and your questions can be anonymous if that's more comfortable for you, and we totally get it. So this is a safe space, but hey, here we go. Let's take a look at this. If I can get it started. I can't wait till I get to ABC.
A new study could make the pap smear a thing of the past. Every woman said, hallelujah. More than 13,000 women will be diagnosed with cervical cancer this year. And now a massive new clinical trial finds that the HPV test is better than the traditional pap smear in detecting early signs of the disease. Dr. Jen Ashton is back. So, Jen,
good morning.
Good morning to you again. Tell us about the study and what this could really mean for women.
So this appeared in the Journal of the American Medical Association. It was a big study done in Canada. They followed women over a 4-year period, divided them into 3 groups. Women who were screened using just the HPV, that's the human papillomavirus test alone. Women screened with traditional liquid-based pap, and then a safety group. And what they found is that the women who were screened just with the HPV test had a lower chance of developing the pre-cancerous lesion that we worry about progressing to cervical cancer. So again, the presence of the virus tended to trump the abnormal cells on the pap smear.
Okay, so there you go. I just wanted to tie in children, women, men, all of us. Okay, so having said that, this is the first timer, you guys, so you're probably scared back there. That sounds like right. So let's be nice. Let's play nice. And we always do. This is a safe space where we have illuminated conversations. And the best part of us coming together, the greatest promise known to man is fulfilled, where 2 or more of us comes together with the same like-mindedness. Something wonderful will happen. And today we're trying to pour into each other so that we can pour into those we love the most and talk about all things booty-licious, but turd cutter. I'm trying to think of names. Here he comes, Dr. Gary Bucher. I used a different intro for you than the countdown clock because I was like, smooth. And plus, you got Hollywood hair, so I gave you some neon. How are you? I'm so glad you're here.
Oh, good morning. Thank you for having me, Lauren.
Yeah.
Wow, you had a mouthful with all of these terms and information. It's tough.
Boy, let me tell you, I'm not kidding you. And I practiced a couple of us. Like, I'm not going to let those words intimidate me, but I don't want to give people any type of misinformation. And that's why I'm so, so happy and honored that we have someone of your stature here today. Tell us a little bit, Gary, if you could, about your journey. I know you got involved. I saw in your bio you got involved with a lot of this, especially back at the beginning of the AIDS epidemic, like around 1989 or so. Talk about your passion for this work that you do.
Right. So I've been in HIV care for a long time, and that was my primary focus from medical school to residency. And I knew that anal cancer was a risk in patients who are HIV and also in gay men who are HIV negative.
Yes.
And my practice, my primary care practice, had both positive and negative men. And by the way, MSM stands for men who have sex with men.
Oh,
So when you brought that up, HIV-negative MSM, or HIV-negative men who have sex with men.
okay.
And
Thank you.
so I started screening in my practice for anal cancer with Pap smears, and I would refer the abnormal Paps, to colorectal surgeons, and they would just put a scope in and say everything looks fine. And I knew that wasn't the right workup, so I went and did extra training on how to evaluate for HPV-related lesions. And in doing so, I incorporated that into my practice, and I'm like, well, no one's doing that here in Chicago.
Mhm.
So there's plenty of HIV primary care and men's health doctors. So I stopped doing that and strictly focused on doing HPV-related anal disease. And I've been doing that for the last 11 or 12 years.
So where are we now as opposed to where we were when you began? Are there big strides?
Finally, yes, but over the course of the last 20 or 30 years, screening for anal cancer in high-risk groups has not been a part of any kind of clinical guidelines or standards of care. So in women, HPV causes cervical cancer and vulvar cancer and vaginal cancer. There was never any a randomized clinical trial that actually showed that treating those precancerous lesions there prevented cervical cancer, any of those cancers. Doctors just were screening and treating, and over time, they saw that cervical cancers decreased from about 30 to 40 women per 100,000 down to 7 or 8 per 100,000. So we know that HPV infects the anal canal, but there wasn't any randomized trials showing that. And these days, you have to have randomized controlled trials before things become standard of care. It's not like the old days when you could just do things, observe, and see the difference. And so during this time, about 7 years ago, a national study was put in place called the Anal Cancer Prevention Study, also known as ANCHOR. It was put together to actually answer that question. The same thing that would happen in cervical, whether in anal canals, whether we could actually screen for these lesions and treat them and prevent anal cancer. And so that study's been going on now for the last almost 7 years.
7 years. Now, a lot of us, Gary, go back to, I remember when our mutual friend, Jonessa, said, you need to get this guy on your show. And I was telling my husband about it. And he said, oh, yeah, Farah. He went straight to the Farah piece. That's what Farah died from. And I said, oh, yeah. Now, that was way back there, right? And I think a lot of people were surprised. Beautiful
Right.
Farah, they thought, ooh, Farah. Been getting it up the old poop chute, which is not talk about that. Why is it we hear about all these other cancers? And a lot of people, I have a feeling that people, you can tell me if you think I'm right or wrong, they may get a diagnosis for anal cancer, but they don't want to tell people it's anal cancer because they're going to think that's like someone, what is all that?
Well, patients don't want to talk about anal issues with their doctors, and doctors don't want to talk about anal issues with their patients. It's like
Really?
that. Yeah. It's a taboo area. People just would rather avoid it.
I know it's difficult, Gary, but
people avoid it, and they can have symptoms for years and never talk to their doctor about having an issue. Or if they do, the doctor usually will say, oh, you just have hemorrhoids, take some over-the-counter Prep H, without even looking or actually even doing a rectal exam. So we're trying to destigmatize all of this because it's really important.
wow.
And in Farrah Fawcett's case, she probably had symptoms for a while before she even had things checked out because, again, most people don't want to check that out. The other thing is that anal cancer really is not that common of a cancer in the general population.
Correct.
So in women, there's about the rate for anal cancer is about 2 to 3 women per 100,000. It's really low. And in men, in the general population, not looking at any other risk factors, the rate's about 1.5, 1.5 per 100,000. So really low.
Wow.
But if you look at these high risk groups like HIV positive gay men, the rate's 175 per 100,000. It's huge.
Wow.
And in HIV positive women and some of the other high risk groups, it's about 30 to 40 per 100,000. So a big problem.
Big problem. Now, really quickly, in case someone, because I know Sherry McQueen, she's probably Googling all over the place right now. So I noticed when I was looking around, snooping this morning, not only did, you talked about the different types of cancer, cervical, on and on and on, but then I saw something that surprised me. I saw it also feeds into neck. And did it say head cancers, neck and head?
Throat, so oropharyngeal, so throat cancer more than anything else in the tongue. Like Michael Douglas, he had HPV-related throat cancer.
Okay.
So actually throat cancer is even becoming more common because of oral sex. And so HPV likes those types of skin cells also, those squamous cells, those types of skin cells that are in the back of your throat, in your anal canal or in the cervix or the vagina.
Mm-hmm.
So it gets attracted to that. And the vaccine you were talking about, the HPV vaccine, actually should be given now that we have it available to boys and girls before they start having sex, because it definitely can prevent those 3 types of cancers: throat, anal, and vaginal or cervical.
So for the parents that are watching, Gary, not to cut you off, but for the parents that are watching, or the guardians, or someone who has a young person that you just described within reach, how does the primary provider say to the parents or the guardians, your kid should get this, or is that something you have to be proactive on and ask about?
It's part of the vaccine schedule, so the medical providers should recommend it, but there's all different types of medical providers. So
Right.
You have to be proactive also to make sure that your child gets the vaccine, because it is the only cancer prevention vaccine that's out there.
Okay.
The one that prevents this. And these cancers are increasing about 2% per year. So even with the things that we're doing, we're still seeing increases in cancer, which is why we need good screening tools and methods.
Absolutely. So let's talk about this one. Now, HPV, is it true? I've heard so many different things, but a lot of people just, in the know, or, just talking to friends and people, laymen, I guess we could say, a lot of them say, oh, we all have some of that HPV. Is that true? It's like it's something everybody has a part of, but if you get tested, talk about isn't it 2 or 3 different kinds that, it's a rating, isn't it? Like if it's this one, it's not that cancerous, or talk about that. I'm getting it
Right,
all.
right. So let me just tell you a little bit about HPV, and it's human papilloma virus.
Papilloma.
Right. And there's over 100 different types, and we break them down into 2 types. There are low risk types and high risk types.
There it is.
So the low risk types can cause warts, kind of hang out in cells, but are not cause any issues. We're more worried about those high risk types of HPV, because those types are the types that have the potential to cause these precancerous lesions that can develop into cancer. And there are some of those high risk types that are even more dangerous, like type 16, 18, 45. In that segment you brought up about cervical testing for HPV, it actually tests for type 16 and 18, because those are the most common types that cause that. But the HPV vaccine covers 9 different strains. 2 of the low-risk strains that are the most common we see causing warts. So basically, if kids would be vaccinated for that, they would not be getting any warts, which is a big deal, because people hate those more than these precancerous lesions, because most of them won't even know they have those.
Right.
And then there's 7 other high-risk types that the vaccine covers. Now, the thing with the cervical clip that you put on there with HPV testing.
Yes.
So we've been treating these cervical precancerous lesions for years, 20, 30 years. We finally got to the point, after all of this time, that we know that the standard of care is to treat those cervical lesions to prevent cancer. But also, we just recently found out that testing for HPV is superior than doing the pap test. So you see how long that took to even come up with that information. So, because they've never really had any clinical trials, they've been slowly doing all of this stuff. But we don't know yet whether screening the anal canal with an HPV test is the screening method we should do, or whether it should be PAPS, or whether it should be a procedure called High Resolution Anoscopy, which is what I do in my office.
Talk about that. That's because I was doing some research there, and people were saying, because you have the pap smears and swabs and all that, but this scope, like you're talking about, is really like the best way to find out what's really going on. So what happens when a person gets the scope? What do you see? Do you tell them something that day, or what happens?
So in comparison, so in women, when they have an abnormal cervical pap or HPV test, they'll have what's called a colposcopy, meaning that they're going to use a microscope. The provider uses a microscope to look at that cervix and the vaginal tissue to magnify it. And they use vinegar and iodine to highlight abnormal areas. So that same technique is used in the anal canal, only there we have to have a different name, of course. It's called High Resolution Anoscopy. And it's just saying that we're looking at your booty cells under magnification. And so when someone comes in to see me, they usually will be laying on their left side, just like kind of when you're getting a colonoscopy. But they're laying on your left side. I have a video monitor. I take pictures of what I'm doing. I do a swab for a pap smear and an HPV test, because that's kind of our screening ways to do it. And then I'll use some lubricating gel, and I'll insert an anoscope about an inch or two. So remember, with HPV, it likes squamous cells. So squamous cells are the kind of skin cells you have on your outside skin. And as that moves in, it goes only in about an inch inside your bottom, changes over to rectal cells, and then colon cells up higher. So HPV doesn't infect your rectum, and it doesn't infect your colon. So we only have to go in only about an inch or two. The scope is not that big. And a lot of patients want to watch the procedure, and I can give them a tour. I point out stuff of what I see. And then if I see anything that looks abnormal, I'll do a biopsy. There aren't any nerve endings there, so people don't even feel them. And I send it off to the lab, and then we see if we have anything that's abnormal.
So let's say, wow, that's a lot to process.
It's a lot to process.
And you said people don't know because there's no nerve ending. So if you have these lesions, you don't feel them. So you're not like, oh, I wonder what I feel like. Is that a lesion I feel up in there? No. So
correct.
How often should a person be screened?
So you can't feel these precancerous lesions. You can't even see them unless you're using magnification or using vinegar and iodine. If you feel something, that's a possible cancer. So then it's already past what we're trying to find.
Exactly.
So typically we want to screen people initially once a year.
Okay.
If they're high risk. And that's with a pap smear or an HPV test. If either one is abnormal, then you should have that high resolution anoscopy. And then depending on what we find, will determine what your follow-up will be. So it might be 6 months, it might be a year, it might be 2 years. It just varies.
Depending on what. So, Gary, is the HPV test, isn't that like a swab?
Yes. So it's just a Q-tip in your bottom that you just rotate.
So that's an out. They just go in and out, boom, boom, boom.
That's very easy. But most doctors that see these high-risk patients don't do those things. They say, oh, I don't have the setup for it. And it's really just a Q-tip inside of your bottom. So they're just not educated or familiar with the screening process. So where does the person
go?
To me.
Oh. Well,
so we screen people. We screen people all the time. You know, there are some providers like Jonessa and other providers that are really more in tune with screening high-risk groups. So then they will do these PAPs and things. So it's my job also to go out into the community and talk to the providers, which I have been doing for years, and educating them about how to screen. But,
oh, wow.
But the excuse has always been, we don't have any clinical guidelines or standard of care to actually show that I should be screening these people. And now we have that information.
Well, Gary, how important is early detection. We hear that. I remember that from a long time ago. Get checked because it can be prevented. They always say it's one of the most preventables. That's what I remember. Is that still the case?
It's one of the most preventable and one of the most treatable. So if you develop anal cancer, so you come in, you haven't been screened, and you have a lump, an anal lump. We do a biopsy, we find you have anal cancer.
Mm-hmm.
So the standard of care for treatment is chemo and radiation. First thing, chemo radiation. So if you catch it early and it's small and it hasn't spread, which most of them that we find are small because, you know, we're screening people. If you find it small, about 60 to 70% of them are treatable and you won't have any recurrence, which is great. But the thing is that you still have, a lot of people can still come in later. It's larger than what it should be, and they might get a recurrence. So you only get one chance at chemo radiation. So you know what happens if it's too big or if it recurs. We actually have to remove the anus. You get a colostomy.
The whole anus?
The whole anus.
No pun intended.
And then you close it up with skin and different flaps.
Wait.
So you can respond well to treatment, but if it recurs, it's bad. And some people, you know, chemo and radiation is not benign either. You have a lot of residual issues from just radiation with like incontinence and chronic pain and all those other things. So even though the cancer might not come back, those side effects from the treatment are still significant.
Ooh.
And then if it does come back, that's your only choice.
Right.
So screening, finding these lesions, and treating them is obviously optimal in these high-risk groups.
Okay, that really informative there. Listen, we're going to take a short break, and when we return, we're going to ask Dr. Gary about this piece. Gary, and I want you to start thinking about it, and you guys get your questions and comments in, and we'll address those when we return too. You know, they say that the rates of anal cancer are increasing in the general population, but specifically with people with HIV, and they're at a greater risk for anal dysplasia, and cancer rates are increasing every year. One thing I found in your bio that I was glad to see, because we hear about it as laymen, say, you know, doctors don't even take any nutrition classes, but I noticed that you actually went to the American College of Nutrition. So when we come back, can you talk to us about things we can do with our diet holistically, or what can we do at the home front level that could help us have a healthier butt? How's that? Okay, that and more when we return. Don't go away. We'll be right back.
It's the Cosmo Sapiens, hosted by the Galaxis Gal and Lauren Michaels Harris.
This is the Galaxis Gal, bringing you the stories of the human beings making space for all of us. Because just like on Earth, in space, humanity should be our business.
Everybody wants to be an astronaut. Every Thursday and Sunday at 8 a.m. and 8 p.m. on iRock Space Radio.
Welcome back to the show. I'm your host, Lauren Michaels Harris. You're in the midst of today's episode of Bathrobe Moments. Before we went to break, I was asking Dr. Bucher about holistic and things we can do, better choices as far as our health. And one of the choices I've made in the last year is to reach for this instead of the old Diet Coke, which I was highly addicted to, and got rid of all those, those drinks that weren't serving me. Let's put it that way. That does not include wine. Just saying. But V8, the original, you know what it is. Remember, this was your mom and your grandma's drink. Well, now it's our drink. Why? Because it's only 60 calories. It's 100% vegetable juice from concentrate. And you get 2 full servings of vegetables in every can. Easy peasy to find. Simply head down your juice aisle at your local grocer and you're going to find it. Don't regret. Make a better choice. Pop the top today. Instead of saying I could have had a V8, oops, say, guess what? I had my V8. Get yours today. Dr. Gary's back on the way in. There he is. Hey, welcome back, Gary. Oh, it's not official. There. I actually swallowed it, V8. Like they do with your pills and stuff. Let me see. So let's talk about nutrition really quickly. Is it true that when doctors go to medical school, they don't have any nutrition classes?
No, we don't. Unfortunately.
How can that be? Anyway, but
it's important, and I'm glad that you actually brought up the fruits and vegetables, because regarding HPV, probably processed foods are not the best thing. Fruits and vegetables are important. Mm-hmm. And there's been some small studies to show that eating cruciferous type vegetables like cauliflower, broccoli, Brussels sprouts, those types of vegetables that have indole-3 carbinol might be beneficial regarding HPV. But I think overall, just in general, trying to avoiding the middle of the grocery store market aisle,
yes,
and staying around the periphery,
yeah,
would be best for
food.
all health.
That's so true. See, told y'all. I wasn't making that up. No, seriously. When I transformed my body, Gary, I had to get out of the habit of going up, down, like for the Reynolds Wrap and stuff, I started going to the dollar store to get that kind of stuff, just so I didn't have, because right across from my Reynolds Wrap were the candy bars. I'm like, these two, they're not even cousins. Why are you doing this to me? So, yeah, stay on that perimeter. Good point. So, you went to the American College of Nutrition. So, let's just talk about that. You said we get those things, the bad stuff. We already know. We know that. But are there any specific things that we can do? Like you hear about gut health and all of that. So let's talk about butt health. Is there such a thing as butt health?
No. So, there is, but not in relation to anal cancer or anal dysplasia. Okay. And when I say anal dysplasia, dysplasia just means abnormal cells. Okay. So there's not any, because it's a viral infection.
Yeah.
So it's not like something that's changing your metabolism or altering, different types of chemicals in your body. It's actually a chronic, persistent infection that over time can cause changes in the genes and in the different things that are going on inside of the cells. But just in general, with everything in general, eating healthy, less processed foods is the way to go.
So, Gary, let's talk about warning signs really quickly. Because, a lot of things, I know a lot of people, everybody know when you wipe, you look at the paper. Don't act like you don't. You do. If you don't, you're just nasty. So I'm just saying, you look, what do you do if you see something that isn't usually there, i.e. blood, mucusy? Do we just dismiss it and go, oh, must have been something I ate, or what? How many times do you need to see that before you say, maybe I should give my primary care physician a call?
That's a good question. So the typical signs for anal cancer are pain, bleeding, and you feel a lump. So if you have any, and when I'm talking about bleeding, it can be on the bowel movement. It can be just wiping with toilet paper. So everybody has a little bit of bleeding here and there when you wipe, because sometimes you wipe too hard or whatever, because, there's blood vessels that are very superficial there.
Okay.
So if it's something that's persistent and consistent each time with blood, or if you were having anal pain pretty persistently over the course of a couple of weeks, or if you feel something that's there, you obviously need to get checked out. Mm-hmm. Those would be the warning signs. So where you need to go get checked. Regarding throat cancer related to HPV, there isn't any screening tests for that. There's no HPV testing or anything. But if you have persistent hoarseness that's chronic, that lasts more than 4 weeks, or if you have a slight cough, or you have to clear your throat that lasts more than 4 weeks, then you need to go to get that checked out also.
And would you go to an ear, nose, throat doctor for something like that?
Most people, a lot of people, if they're in certain types of insurance, have to have referrals. So if you have the type where you can just see whatever specialist you want, then that would be appropriate. Most people start with their primary care doctor and they get referred from there.
Okay. So Gary, with like colonoscopies, we're always told, I remember it was like when you hit 50, that was the the big giant sloth that stood in front of me as soon as I turned 50. That and the constant stalking by AARP. You know what I'm saying? They are on your ass. Literally. There's another bunch of so what about this type of testing? Is there a specific age category where you should start incorporating it into your yearly physicals and whatnot?
Well, that's one thing that the Anchor study, the anal cancer prevention study, was wanting to answer. We do know that anal cancers occur in older groups of people. So in women, the average age is 60. So much older than when they get cervical cancer, which would be in their 30s.
Wow.
So in HIV-negative men who have sex with men, it's about age 50 to start screening. HIV-positive men, we usually start around 30 or 35 because it happens earlier.
Okay.
In the Anchor study, it was going to give us, the Anchor study was set up to enroll people 35 years plus, men and women. Because we know that we want to make sure that in that study, some people, it's a randomized trial, we're going to develop cancer. If you enroll people that are younger, the likelihood is really low. And so what the Anchor study actually showed, which is one of its primary endpoints, is that we wanted to see whether treating these precancerous lesions would prevent anal cancer. And people were randomized to either one of two groups, where we just watched them in half of the people, or whether we treated the other half. And a couple of weeks ago, the study was stopped for enrollment in screening because it showed that treating these precancerous lesions will prevent anal cancer. Mm-hmm. We have a data safety monitoring board that actually looks at the data. Us investigators don't get to see that. And they saw that we can't continue this trial and having people that are not being treated because it's such a significant difference in that in the treatment group, they weren't getting cancer as many compared to the monitoring group. So the study has closed to enrollment. We've proved our primary endpoint, and then eventually this will become a recommendation in all the standard of care clinical guidelines that we should be screening and treating high-risk people to prevent anal cancer. So it's huge. It's a big thing that happened a couple weeks ago.
And it's very encouraging because even though it's like a hush-hush taboo kind of a thing, this work that you guys are doing, you and people like you across the world, would you think that someday, in the not so distant future, that it's possible that through this type of testing and early detection, we could pretty much eradicate?
So we will definitely decrease the incidence. We don't have any treatments for these precancerous lesions that totally prevent anal cancer. So in the study, for instance, we've had some people in the treatment arm that developed cancer, but we had many more people who didn't get treated that developed anal cancer. So you can still get it because it's difficult to treat, but the majority of the people that were treated did not get it, which is a good thing.
Have you, in your journeys, ever crossed a person or people that you say, you know what, this is happening and you need to do this next, this is the treatment for it, this is the protocol, and they still won't do it and then later regret because it turns into full-blown anal cancer? I mean, or have you ever caught people right at the nick of time and go, wow, what a smart move? Talk about that dynamic, because I think a lot of people are surprised. They go in expecting nothing, and it's something, or they go in thinking it's something, and then it's nothing. Oh, you just had hemorrhoids. Oh, you just had this. You don't have, talk about that.
So for the most part, people that are in these high-risk groups, they're pretty surprised that especially if they have a lot of these HSIL lesions or these precancerous lesions.
Okay.
The ideal thing to be when we're screening people and we're doing high-resolution anoscopy, we're finding that the cancer that's so small, it's almost removed with just the biopsy. And the biopsies are tiny. They're like a sesame seed size.
Wow.
So there is a clinical trial going on to look at these cancers that are on the inside. If they're really, really small, if we can just remove them surgically, if you get all the border, so that you don't have to do radiation and chemo, that can be reserved for if you develop a larger cancer.
Mm-hmm.
So the ideal, I'm always surprised, sometimes we find a tiny little cancer that is just totally removed with the size of a sesame seed. So I'm surprised as the patient's surprised, but the patient's even more surprised that they could even have cancer. But those patients, I don't always send to have chemo and radiation. So if the cancer is really small, and if we're screening lots of people with this, we should be able to reduce the incidence of anal cancer significantly.
Right. And the fact that there's no pain or anything is the reason you want to get checked. Because if you feel something, you've waited too long.
You've waited too long.
I don't know what right.
I don't know. And you would be surprised on some of the tumors I've seen that have had to be there for like 2 or 3 years. And I just am like shocked that someone could have that down there and leave that down there so obvious for such a long period of time.
So if someone has something of a sizable lesion or whatever, would they feel that during a bowel movement? Would there be some kind of a
they would just feel it with their finger.
Oh.
Some of people that come in, they're like, it's like a golf ball size.
Wow.
And they're so afraid they've avoided to even get checked out. Or if they've gone to their doctor for their annual exam, it just shows you that they're not very thorough because they're not doing a full, complete physical, which your anus is part of that physical exam.
Well, the conversation today, everyone, is about butts, and there are no buts about it. So I just have a couple questions for you, Dr. Gary. Do people ever accuse you of being anal?
Yes, all the time, especially my husband.
Right. And do you get, I'm really serious about this because my husband's a therapist and he gets everything from board games to notepad, all the therapist stuff. People feel like I'm going to be original and give him something to do with butts as a gift do you have like a collection?
I do. And actually I like it. Some of the big things, a lot of practices also have butt pictures on their wall of not of people butts, but of animal butts. And yeah, so it's kind of cute.
It is.
I don't mind.
I know. I was going to say, I can imagine visiting your office is pretty much for people to paint in butt.
It is.
Okay, so I have 3 good butt jokes, and it's called Stump the Butt Doctor. I have 3 butt jokes that I found that I'm hoping you've never heard, so you can add them to your repertoire. Okay, here's the first one. The last one's my favorite. I cracked up for like 10 minutes. Okay, yesterday, Gary, somebody butt dialed me again. It just appears that only assholes want to talk to me. Okay, doctor laughed. Okay, second one. Oh, this is good. Why does toilet paper never cross the street?
I don't know.
Because it doesn't want to get stuck in a crack.
That's a good one too.
That's a good one too. I only had to go through 40. Most of them were lame. Last one. This is my favorite one. I think don't judge if you don't laugh at this because I did. Don't judge. What would the cannibal do after dumping his girlfriend?
I don't know.
Well, most likely wipe his butt. See, that was the best one of all, wasn't it?
That's good.
What would the cannibal do after dumping his girlfriend? Oh my God. I was like, that's good. Stop at that one. So,
yeah, you have to have a sense of humor,
You really do. You really do. So Gary, let's talk about your passion, if we could, as we got about 10 minutes left. And, you know, as a physician, what was it? What was your mindset when you first started? When you were a fresh doctor, were you just a GP? Did you go back and specialize, or has this always been something for you?
Well, I wanted to be a doctor since I was in 8th grade in high school. I got my foot in the lawnmower, and I was mowing the grass. I was pulling it behind me. My foot slipped, and I was, I'm from a small farm. There was only 20 people in my high school class.
Oh, wow.
So I was in the hospital for a week with my foot, and that was my first exposure to being around medicine and doctors. And so I was like, I think I want to be a doctor. So during high school, that's what I strive to do. And I'm from Missouri. And in Kansas City at University of Missouri, they have a 6-year program where you get your BA and your MD in 6 years. So instead of going 4 years college, 4 years medical school. So I was accepted to that. And so I graduated 2 years earlier than what most people would be, and went into family medicine, came out in college, and I was like, I wanted to have a gay men's health practice. And so that's what I always had from the very beginning. It was primary care. It was all HIV because no one wanted to take care of any of the HIV positive patients. So during the first, 10 years, it was very tough. I had lots of friends die, lots of patients die, and it was every day. And so I left HIV medicine after a while. In like 2000, I needed my husband, my partner died, and I needed a break. And I went to San Francisco, got a motorcycle, and did urgent care and just kind of other stuff for like 6 years. And then I came back, and now I've been gung-ho into it again and found my little niche.
Yes. And I noticed when I was doing the research, I forget his name, but there's another guy who's doing the anal dysplasia thing. It's moving across the country, right?
It is. So with Anchor, we had 22 sites, and we've been training and everybody in these sites. But obviously, with the results of the study that show that everybody should be screened and evaluated, there's going to be a bigger need. And there's 4 providers in my practice where we're all trained and certified very intensely because we were part of the study, but there's going to be a need for more providers. I also provide care over at Howard Brown Health Center and do their HRAs for their population over there. So we're working on also spreading that out, but right now we're the place to go in Chicago.
That's awesome. I wanted to know, just for shits and giggles, when it comes to, okay, we know the high risk groups and this sort of thing, but what about ethnicity? Is that ever a factor? Does one ethnic group, do you find that they're more at risk than another?
So I think, this is all of the stuff, the natural history stuff that we're collecting with Anchor. And we were really proud, and the National Cancer Institute, who sponsored the study, was really proud because about 60% of our patients were African American. They almost never have clinical trials that have such a huge representation. About 4% were transgender. So we see a ton of, yes, anal cancer has been more of a gay, white, male thing, but it's actually converting more into more of a cancer in African American, HIV positive young men and transgender. So, which is why we were really pushing to bring more of that populations into the study, which we were really successful with.
And even though those people, like you said, where you're finding it primarily, do you think this work will one day benefit all people?
Well, it's such a small incidence cancer. Mm-hmm. It's not really going to need to affect all people because in the general population, like I said, the rate's really low. Mm-hmm. But in these high risk groups, so again, HIV positive men and women, HIV negative men who have sex with men, women with vulvar cancer, transplant patients, that have had transplant for 5 years because they were immune suppressed for a long
Yeah.
period of time. In those high risk groups, it's going to be huge. It's going to be a big deal.
Awesome. Now, this, I know this may sound a little weird or crazy, but I just gotta ask. You know, when your peers, fellow doctors that specialize in other things, do you know, just like special ed teachers always report, because I speak in front of a lot of them because of burnout and things, and they report that they always feel like they're second class citizens, that their peers feel like you're not really a teacher or this and the other. And in many cases, you know, there's not a job for a successful person working in that specific area. It's more of a calling, I would think. So I just want to ask you, do you ever feel like this issue is not taken seriously enough by other doctors and other specialties and things?
All the time. Especially since they're like, why should we be checking if they're not any standard of care clinical guidelines? The other thing that was really bothering my colleagues that are colorectal surgeons who do what I do, the surgery community says that's not an issue at all. So my colorectal surgeons that are in this field, which we definitely need, because some people do need surgery, they feel really vindicated and validated that this is a very important area that we should be, checking patients on.
Awesome. So along the bottom of your screen, you'll see on the ticker, adcmidwest.com. Gary, tell us, if they click there, what are they going to find there?
So that's my practice website. So it has a listing of talks about what dysplasia is, has the clinical trials that we're doing, because we still have other clinical trials. And it also shows all of our providers and a little background on who we are and what we do.
Awesome. And then we have this. Tell us about this.
So if you Google search HPV or anal dysplasia or anal cancer, there's so much crap out there. Like so much misinformation. Oh, I got one.
You did.
So this website I give it to all my patients. It's the most credible information that you can have from University of California, San Francisco about dysplasia and HPV and cancer. So if you want more information, don't Google, go to that website.
And I just dropped that website into the chat to make it even easier to gain access to this great information, and most importantly, credible information. So remember, if anything, I know one takeaway for me today is to be proactive. If you have not been checked for HPV or just all of the things that you've heard here today, please talk to your provider about having that done, incorporate it into your yearly or biannual physicals, whatever the system is for you, whatever you do, but just do it. I did. I went and had it checked. I'm in that high risk area, but even if you aren't, just because it isn't talked about as much as it should be, doesn't mean it isn't something that we need to be talking about. So keep that in mind. And Gary, final thought, Gary Springer moment, Gary, anything you want to say or leave people with that you feel like if they were to forget everything we've talked about here, please don't forget this. What would that point be?
Well, I think you just said it. If you're in one of those high risk groups, you have to be screened for anal cancer because your risk of getting it is very, very high, and you can catch it early and hopefully prevent you from developing cancer, which is really hard, to avoid all the side effects with the treatment.
Right. And again, finally, don't keep this, well, it doesn't apply to me, so it's not important to me.
Right.
No. Bless somebody with this information. Who do you know that falls into any of these high risk groups? Send them the link. Shoot them the link.
Absolutely.
Right. It doesn't cost anything. You're not going to bleed, at least for very long. So give it a shot, try it. And if you have more questions, on your screen are 2 ways to get some answers. Gary, thank you so much for all the work you're doing. Thank you for, I'm so proud, the LGBTQI plus community is proud to have you as a member and working to just make this world a better place for all. I really appreciate you, and thank you for coming. You're welcome back anytime.
Great. Thank you. Thanks for having me. Yep.
You're welcome. You guys, listen, here's my task for you today. Get out there and be the very best version of yourself. How? Easy. Remember, you're here already, so you're already great. You're already nice. You're already bright. Look for 1E. and one R. Push them over directly to you. And now take everything you are. Take great to greater, bright to brighter. Take bold to bolder. I'll see you out front tomorrow morning at 8 a.m. Central. I'll meet you on the front porch. Tomorrow, my guest is Kessa Gooden. You might remember her. She was and still is, one of the foremost authorities in this country on narcissistic relationships and how to identify if you're inside of one. That and more tomorrow as we come back for our next installment of Bathrobe Moments. Have a great day. Be good to yourself, but be even better to everyone else. Gary, thank you. Bye, everybody.
Bye.
See you tomorrow.
Show me your soul. Baby, I'll show you mine. Show me your soul. Honey, it's way past time. How explicit do I have to be? Need I spell it out before you get it, baby? Show me your soul. And honey, I'll show you